Parkinsonism is a disease of my basal ganglia. Basal ganglia is a part of the gray matter in brain. The gray matter is composed of my cell body and the nuclei of the neurons. It has further the gray matter, the basal ganglia is a collection of nucleus. So nucleus ki ashe dekhane ekbar. Nucleus er mudda we have these are the major nuclei. So this is the globus pallidus externa, this is the globus pallidus interna, this is the putamen, this is the caudate nuclei, this is the subthalamic nuclei, and this is the substantia nigra. Now these two, the globus pallidi and the putamen together are known as lentiform nucleus, and the putamen along with caudate nucleus is known as striatum. All of these are inhibitory nuclei. The only positive excitatory nuclei is the subthalamic nuclei. Now we have to know about the basal ganglia pathways. There are 4 pathways: direct, indirect, nigrostriatal, and hyperdirect. Direct pathway helps in movement. Indirect pathway inhibits movement. Nigrostriatal pathway has 2 types of neurons, D1 and D2. The D2 neurons inhibit the indirect pathway, and the D1 neurons activate the direct pathway. Thus, this whole setup helps in movement only. And if there is any damage, so basically in Parkinsonism only, this nigrostriatal pathway is damaged. So if this nigrostriatal pathway is damaged, there is no activation of the direct pathway by the D1 neurons, and there is no inhibition of the indirect pathway. Thus, the movement that was earlier facilitated is now reduced. This causes reduction in the planning, coordination, and preparation of motor movements, leading to bradykinesia. So this is the pathogenesis of Parkinsonism. Now another physiology integration is the circuit. So the circuit is something not required right now to understand Parkinsonism as such. So now Parkinsonism. This is the pathogenesis. I think we have it here as well. There is degeneration of the dopaminergic neurons, and there is deposition of intracytoplasmic bodies or Lewy bodies. Thus, there is a nigrostriatal pathway defect. The D1 pathway is inhibited, and both pathways are inhibited actually. So here there is slowness of movement, and this is the physiological correlation, but I don't think it's needed right now. They won't ask this to you ever in medicine. So now Parkinsonism classification and features. So before that we need to know about Parkinsonism. So the second most common neurodegenerative disorder, the first one is Alzheimer's. The genetics, or rather let's first speak about the classification. We have primary Parkinsonism and secondary Parkinsonism. The primary Parkinsonism etiology is basically genetics mediated. There are 2 genes, PARK1 and PARK2. One forms alpha synuclein, and PARK2 forms the protein parkin. Secondary causes, and then primary can be further have a 80-20 division. 80 is typical, 20 is atypical. Atypical Parkinsonism generally, basically the cardinal features that it is not responsive to L-DOPA, has no tremors, and basically it is has a faster progression. Now if I need to describe thoda, it's of two types. We got tauopathy and we have alpha synucleinopathy. So for remembering purposes, tau means taurine. Taurine, if you can remember, it's a bile salt. So where is bile salt seen? It can be seen in CBD. So the first example is CBD, that is not common bile duct, that is corticobasal degeneration. Then in the same category only we have what is known as PSP or progressive supranuclear palsy. In alpha synucleinopathy, basically we have MSA, that is multiple or rather multiple system atrophy, and DLB, that is diffuse Lewy body dementia. If I need to speak about thoda features, C, so there is cortical degeneration and clonus. In PSP there is basically postural instability, and postural instability होता है, bilateral axial rigidity होता है. And then in MSA and DLB, DLB is diffuse Lewy body dementia, तो Lewy bodies मिलेंगे, dementia मिलेगा. And MSA is multi system atrophy, इसमें mostly my ANS system predominate and we have cerebellar signs as well. And DLB में एक extra feature है that there will be hallucinations, visual, and also there will be fluctuating alertness. Alertness is also impaired. This is not required, I am just saying to complete the discussion. Atypical Parkinsonism in itself इतना नहीं चाहिए होता है. Remove them. So moving to typical Parkinsonism, we have two types again. We have tremor predominant and we have akinetic rigid syndrome. So tremor predominant just basically happens in 65 to 70 years. This happens more than 75 years. It has a slower progression and a better prognosis. And this is the opposite. It has a faster progression and worse prognosis. Now secondary Parkinsonism can be remembered with the mnemonic called deep waves. D is drugs. Drugs may we have dopamine receptor antagonists like metoclopramide, or neuroleptics like any antipsychotic drug. It may be typical, it may be atypical. Typical includes haloperidol, and then atypical includes clonazepam, risperidone, then olanzapine, etc. From we have infections, I, like encephalitis, meningitis. By P we have poisons or toxins. We have one called MTTM, and then we have manganese. W is Wilson's disease. We know that in Wilson's disease there is copper deposition in the substantia nigra that causes degeneration of it. In A, basically we have anoxia or hypoxia. In V we have vascular insult like stroke. E में we have endocrine causes like एक number तो hypothyroidism also. And in S, basically the thing that we have is, you can see here, if we go here, by S we have structural lesions like NPH, normal pressure hydrocephalus. Then we have structural lesions like tumors or any trauma. is the type. So after we finish the types of Parkinsonisms, we have to discuss the symptoms. The symptoms are basically sensory, motor, and that are related to my cardinal symptoms. The cardinal symptoms can be remembered by the mnemonic TRAPIGA. Trapiga. T is tremor. The tremor is resting tremor. There is a low frequency tremor that is relieved by L-DOPA. That is mostly, restricted to the hands. Sometimes maybe restricted to the feet as well, and that is how we mainly differentiate it from the essential tremors. By R we have rigidity. Rigidity is two types, cogwheel and lead pipe. It is velocity and length dependent, caused due to extrapyramidal lesion. By A we have akinesia or bradykinesia. P we have postural instability, and by G we have gait abnormality. So about the posture, basically a person having Alzheimer will have the posture like this. It will be a stooped posture due to axial flexion hypertonia. The hand movements will be reduced. The feet, the steps will be really short, and all of these features will result in a festinant gait for the person. So this is about the cardinal features. Now for the motor features, basically we will draw a diagram. Before, let's discuss the sensory features. Sensory features में we will have ANS symptoms like bowel, bladder symptoms, erectile dysfunction. That is the most common one. Then we have anosmia, loss of smell. Then we will have peripheral nerve dysfunction, like pain in the peripheries. Then we can have other sensory features as well, like mood disorders or psychiatric mood disorders. Now for this finishes the cardinal. Now for the motor features, we have draw an eye, nose, two lips, a body, small hands and big legs. So from here, basically first ears as well. From eyes there will be reduced blinking. Then in ears there will be hypophonia, or it will hear less. Then in face there will be hypomimia, so the expressions will be limited. Mouth there will be dysphagia. The hands are really small, you can see, that will have micrographia. So these are the main motor features. Now moving forward to the diagnosis. Diagnosis is mainly clinical. We can do an MRI of midbrain. have two major findings. Normally, the substantia nigra causes a swallow tail appearance. This swallowtail appearance will disappear since the substantia nigra is degenerated, and there will be bilateral hyperdensities in the gray matter surrounded by hypodense fibers, spinal fibers, and red nucleus. So this is the diagnosis, and then we fast forward to management. Management, we have 4 lines of drugs. First, we have L-DOPA substitute, so with peripheral dopa carboxylase inhibitor like benserazide or carbidopa. We have dopamine receptor agonist like pramiprazole, ropinirole. Then we have amantadine, it's antiviral. It has NMDA receptor blocking, centrally acting anticholinergic action, and also dopamine agonist. Also, there is a fourth drug, that is my centrally acting anticholinergic that is helps in drug induced Parkinsonism. The drug is trihexyphenidyl. So now lastly the convention of treatment is we have to look at the age of the patient and the symptoms. So if the patient is generally less than 60 years or more than 60 years, if it is less than 60 years basically, then the dopamine receptors are still present. So we can give dopamine agonists like pramiprazole, ropinirole, they are the drug of choice. But if it is more than 60 years, the receptors may be down regulated. So we directly start with L-DOPA and carbidopa. This is the management. Here you can see the same thing is written, pathogenesis. This is the classification and features. You can screenshot it or watch it, I don't know. Then cardinal symptoms, here the tremor is described here, rigidity, some important features that I just explained, diagnosis, treatment, and side effects of anti-Parkinsonism drugs. If you want to study, you can study. That's it.